Overcoming the dilemmas in ptosis surgery. What is dilemma? Origin is from Greek, a double proposition. Other definitions are a situation where you have to make a difficult choice or undesirable, unpleasant choice. Dilemmas may be in the planning stage or after surgery has been done. The examples which are shown do explain what all dilemmas a surgeon can face. Ptosis is the commonest and difficult problem an oculoplastic surgeon comes across. In ptosis correction, not only the functional aspect but the aesthetic aspect is equally important. The pre-operative counseling is important to make the patient and the caretaker to have a realistic understanding of the problem. I hope the presentation would help in clearing some of the doubts. Blepharoptosis or ptosis is the most common eyelid disorder encountered in oculoplastic surgery. The result of ptosis correction in a congenital ptosis, which is expected by the patient and the surgeon, is not possible in every case. The results of ptosis surgery are unpredictable. In small children, examination is difficult. To choose the method depending on the levator action becomes very difficult. Early surgery if pupillary area is covered to avoid vision compromise. 3 to 5 years is the ideal age, but earlier if needed. Unilateral severe ptosis in an 8-month-old child to help the child to see better and look better. This is what was done. It is better to choose frontalis sling with a silicone rod for ptosis correction. Post-operative care is very important. Frontalis sling should be unilateral or bilateral. Unilateral also gives good result. Bilateral gives better cosmesis and symmetry. Can we do levator resection when the action of LPS is only 3 millimeters? Here you see a patient with a severe ptosis with poor levator function, operated at the age of 5 years. Undercorrection was expected and explained to parents. Surgery done to clear the visual axis. A second surgery during teenage was done, and here you can see the result of the revisional surgery at the age of 18 years. Blepharophimosis syndrome is a rare complication, epicanthal fold with telecanthus, ptosis, narrowing of the horizontal fissure, that is phimosis of the eyelid. First stage we do epicanthal fold correction with telecanthus correction. Second stage only ptosis correction with frontalis sling. Both should not be done together as ptosis increases after telecanthus correction and the lid is tighter. Overcorrection in a ptosis case, which improved with conservative gentle massage in 4 weeks' time. Another case with an overcorrection, the surgical correction was done within 7 days as the patient was keen on it. Revision surgery in a superior rectus weakness undercorrection is planned. Raised eyebrow which the patient had preoperatively has come down after ptosis correction. Beaking can be avoided by preoperative marking. Asymmetric bilateral ptosis. Levator resection under local anesthesia. Very important to check the Herring's law. Patient to be prepared to undergo ptosis correction on both sides if necessary. What is Herring's law? Both levator LPS receive the same level of innervation for motor power. If one eyelid is ptotic, the reflex action causes contralateral eyelid to be slightly overstimulated to enhance the ptotic eyelid position. When ptosis is repaired, there is reduced stimulation to both the sides. This causes appearance of ptosis in the contralateral eye. This may have to be corrected. It's important to check it preoperatively. Myopathic ptosis results from any pathology that affect the levator muscle. Mitochondrial myopathies like chronic progressive external ophthalmoplegia, progressive inability to move the eyes and eyebrows, Cairn-Sayre variant of mitochondrial myopathy, oculopharyngeal muscular dystrophy, or myasthenia. Chronic progressive external ophthalmoplegia due to weakness of the orbicularis oculi muscles. An undercorrection is desired. Levator shortening is the treatment. Infiltrated with fat, the muscle fibers are pale. Correction is sustained in this case, which is shown after 1 year too. Oculopharyngeal muscular dystrophy is a hereditary autosomal dominant, slowly progressive disorder with onset during middle age. There is bilateral ptosis with dysphagia as the orbicularis function is intact. Correction of ptosis is by frontalis sling. Myasthenia case diagnosis after eyes test shows elevation of the ptotic lid. In older patients coming with recent origin of ptosis, this test is very useful and can be done easily in the office. Post-traumatic ptosis. When should it be done? Wait for 6 months and a complete recovery is seen. Pseudoptosis. What are the causes? Hypotropia, dermatochalasis, brotosis, contralateral retraction. All these have to be checked up. There is insufficient posterior support of the eyelid, decreased orbital volume. If deficient orbital volume is replaced, the ptosis improves. Enophthalmos, microphthalmos, phthisis bulbi, enophthalmos all produce phthysical eye, which produces ptosis also. Phthysical eye in a socket, the ptosis is corrected with a CMP. Ptosis and corneal opacity. For aesthetic reason, it is corrected with a colored contact lens. Plexiform neurofibroma. First stage, debulking, temporal area, upper eyelid and lateral canthoplasty. Second stage, direct browplasty and elevation of eyebrow with contour threads. Pupillary area is cleared in this patient. A case of a plexiform neurofibroma in a young girl, a wedge excision of the eyelids along with deep bulking of the temporal area was done. Another patient who had a severe ptosis due to plexiform neurofibroma, and as the patient was very keen to something to be done as the other eye was developing vision problems. And here you can see the correction which was done by debulking. Severe brotosis in an elderly person. All it needed was mid-forehead lift, which lifted up both the eyebrows also and gave her a good vision. In adults for secondary revision surgery, local anesthesia is preferred. To assess the correction, patient is made to sit on the table. A mirror is shown to the patient to get their opinion. And the decision to correct or not and amount of correction depends upon the pupil size, corneal sensitivity, tear film function, and Bell's phenomenon. And thank you.